Hey guys, welcome back. We will now be focusing on the theoretical aspects of tricuspid stenosis, and in majority of cases this disease can coexist with the mitral stenosis, and therefore there is a fair amount of possibility that it may not be diagnosed right away. Let us see why. What I've done in this line diagram is that I have shown coexistent mitral and tricuspid stenosis thanks to the common etiology that they'll be sharing, which is rheumatic fever. And now, because you can see that the amount of blood that will be able to enter into the left ventricle would be lesser, so these patients would be initially having symptoms of effort intolerance. The disease we are studying is problem related to right hand side, but initially the low cardiac output can be explained by coexistence of mitral stenosis. As time will pass, the pressure in the left atria will begin to rise, and that will also contribute to left atrial dilatation, structural damage to the left atria. The same pressure is now going to be transmitted to the pulmonary circuit. So I'll just modify the diagram here to show that now there is a development of pulmonary venous hypertension in the patient. As the back pressure changes will manifest, this person will also be having dyspnea on exertion. Pulmonary edema will also start coming in. And therefore, because of this long-standing pulmonary edema, mark my words there, long-standing pulmonary edema, the same patient will also start developing pulmonary artery hypertension. This will make the right ventricle work harder, and therefore there will also be a compensatory right ventricular hypertrophy as I've shown in this diagram, and therefore the diastolic pressure of the right ventricle will increase. Now I will quote Harrison. He says that tricuspid stenosis is literally a blessing in disguise for this person of mitral stenosis, because the obstruction which is present due to tricuspid stenosis will prevent the transmission of this back pressure towards the right atria. You can see at the moment right atria will be relatively spared, primarily because this tricuspid stenosis narrowing will be acting like a barrier. So let us just jot down what will be the initial complaints of these patients. The MCQ could begin by describing dyspnea on exertion and orthopnea, which is primarily because of the pulmonary edema component. And therefore, I also got an echocardiography of the patient done, but the radiologist was focusing on the clinical domain. So he mainly focused his probe on the left side of the heart and identified mitral stenosis beautifully. But because tricuspid stenosis at the moment was mild, maybe it was missed. Therefore, considering these symptoms, we have already done a percutaneous mitral balloon valvotomy of the patient. So we have now got rid of the mitral stenosis component, and I thought that this person will do fine. But unfortunately, in spite of doing a percutaneous mitral balloon valvotomy, there will be features of right-sided congestive heart failure that will be developing in this patient. So let us look at what is going on, that in spite of a therapeutic procedure with documented success being done in the patient, I am wondering to myself what really went wrong. I did everything right. I identified mitral stenosis, I treated it. But still there are features of right-sided heart failure that are developing in the patient, because now tricuspid stenosis will manifest by contributing to substantial increase in the right atrial pressure. See, initially I was saying that mitral stenosis causes back pressure changes, so tricuspid stenosis per se will act like a barrier to the backward pressure of changes, or I would say backward transmission of pressure. But at the moment that I'm saying is the disease itself will have its own ramifications, because now it is present alone in a patient. Therefore, this is going to contribute to development of congestion in the superior vena cava, congestion in the inferior vena cava of the patient, and as a result of it, there would be a hepatomegaly. This hepatomegaly will be described, obviously the patient is not going to say that. The person will be complaining of persistent abdominal fullness and discomfort in the right upper quadrant. And if there is increased pressure in the inferior vena cava, this will also contribute to increased pressure in the portal vein. And therefore, no big deal that even ascites can develop in these patients. The venous return will also be hampered because of the increased pressure in the IVC. So pedal edema will also develop. And these are standard features that you see with patients of right-sided congestive heart failure. There would be abdominal fullness, which will cause even ascites also will contribute to abdominal fullness. So one of the predominant complaints that will develop in these patients now will be swelling in the feet, and as well as development of abdominal fullness. And therefore, if it's not treated, this congestion in the liver can even progress to development of cardiac cirrhosis. Though that I would say that's a little far-fetched, because we will be able to pick up that there is some other disease that was missed by us initially. So let us now look at what will be the examination findings of this person, which will prompt you to think in terms of tricuspid stenosis unmasked after the treatment of mitral stenosis by a percutaneous mitral balloon valvotomy. On physical examination, one of the very standard features that you will always notice will be presence of large A waves in the patient, which is explained by the fact that the right atria is having to work against pressure. I have spoken about this even in my discussion of JVP and heart sounds, but I'll just draw a line diagram to highlight this again. One, I am showing in this particular diagram that because tricuspid stenosis is present, so therefore there would be increased pressure in the right atria. This pressure will contribute to the right atria having to generate more force to push blood in a forward direction, which will cause this jugular venous column to go up higher than normal, and that explains the large A wave. At this junction, I want to say that there is a possibility that in the exam, he might actually ask you about isolated tricuspid stenosis also. Then the question will not talk about features which I highlighted in, I would say, rather bold initially. These are features which will be written if the two are coexisting. But if in a question he decides to ask isolated tricuspid stenosis present in a patient, I agree it's rare, but if it is present, then these features will not be present. It will be mainly features of right-sided congestion that will be manifesting in the form of what I've explained, the pedal edema component, the ascites component, and even hepatomegaly or abdominal fullness. Another problem that you will be able to identify, especially with respect to the JVP, will be related to the Y wave. Now you very well know Y wave is related to relaxation of the heart. So I'm going to just draw this line diagram once again before you to say that because there is a narrowing present, so therefore because of this substantial amount of narrowing, the amount of blood that is able to enter, imagine this is the stage when there is a rapid ventricular filling occurring, the amount of blood that will be able to navigate across this will be relatively lesser, and at the same time because this is acting like an obstruction, so therefore the Y descent in this patient will appear blunted. What I have done symbolically here is that instead of showing a traditional Y descent the way it should be, I have tried to symbolically represent with a smaller red arrow that Y would be blunted, and that's again important from the exam perspective because we are used to reading about steep Y descent. I have discussed situations where we get a steep Y descent, but this is one of the first times that I'm highlighting the term blunted Y descent. So the statement that I'm writing on the slide at the moment, I would suggest that to be remembered as one of the important pickup points in the MCQ, because in any clinical question, the stem of the question will have some pointers present. So the message at the moment learned is if the two are coexistent, it will be still easier for you to pick up because he's going to give that classical history of balloon valvotomy being done. But if he's going to talk about isolated tricuspid stenosis, then the main pickup point would be large A wave with a blunted Y descent. Another feature that can be especially very useful for identifying this condition is pulsations in the liver. Now the point is the pulsations of the liver, are they systolic or are they diastolic? Let's have some logic into it. Tricuspid stenosis operates in diastole because you see tricuspid valve is for filling of blood in the heart. So during diastole, when the blood is trying to come into the right side of the heart, there's a physical obstruction. So therefore you will be always reading this term pre-systolic pulsations of the liver, and as you will progress in this discussion later, you will notice me saying systolic pulsations of the liver. You see, one word is changing the entire domain. If I say systolic pulsations of the liver, it means right ventricle blood is going back to the right atria and therefore is causing pulsations in the liver. And when would RV blood go back into RA? Tricuspid regurgitation. So if you read systolic pulsations of the liver, it's going to be tricuspid regurgitation. But if you read the word pre-systolic pulsations of the liver, the reading of words is of paramount importance fast in the MCQ, because ultimately you get about 1 minute approximately to solve a question. In that you have to read the entire clinical stem and read the options and exclude the 3 options and get to the right answer as well. So it's the word pre-systolic pulsations of the liver which is to be remembered. I would like to say that if he is not gonna be specific and if he is gonna not at this moment want you to make a diagnosis, he will just say the word pulsatile liver. Though pulsatile liver is also described in the earlier part of the app with respect to aortic regurgitation. Just now I have taught you it can be seen with tricuspid stenosis and tricuspid regurgitation. Technical inputs are provided with respect to tricuspid stenosis because it operates in diastole, it's going to be pre-systolic. TR operates in systole, so it's going to be systolic pulsations of the liver. And now I'll be focusing on the murmur. Just like mitral stenosis contributes to a mid-diastolic murmur, a tricuspid stenosis will also contribute to a mid-diastolic murmur in a patient, Now I have to differentiate whether it's going to be a murmur, mid-diastolic one originating from left side of the heart or the right side of the heart. So you very well know that you will be asking the patient to take a deep breath, because on inspiration, because blood is sucked towards the heart, all right-sided heart events tend to become louder. I repeat my statement. On inspiration, when you ask the patient to breathe in hard, the blood will be sucked towards the heart. More blood will increase the turbulence. So all right-sided events tend to become louder on inspiration, and that is what I have highlighted here before you. In mid-diastolic murmur or mitral stenosis, you will not have a increase in the intensity of the murmur, but in tricuspid stenosis, the murmur intensity will definitely increase. You will be able to hear this murmur on the left lower sternal border. That would be tricuspid area, primarily I would say very close to the tricuspid area. And the main message is that tricuspid stenosis can exist isolated also. I mean, there was a situation in NEET PG 2021 where they gave a isolated tricuspid stenosis, which was mainly related to large airway blunted wide descent and features of isolated right-sided involvement like pedal edema, etc. given in the question. There was no pulmonary edema explained. So I want to make it very clear before you that do not expect that every question is going to talk about only a rheumatic. I agree, in India rheumatic heart disease is common, so that's our thought process as an Indian doctor, but then they expect us to realize the fact that if it's going to be isolated, then the standard features that I've written on the slide and I've highlighted a couple of times are not present. We shall now be doing ECG of these patients, and the first test will be revealing presence of large P waves. Now the definition of the word P pulmonale would be a vertical height of the P wave more than 2.5 millimeter when it comes to the limb lead criteria. But you have to read the question carefully, because if he's asking about the chest lead criteria, then it's gonna be more than 1.5 millimeter. I'll just zoom into the ECG to highlight this rather very spiked P wave which is present, visible in both V2 as well as V3, also in V1, but I just put some pointers here to highlight the fact that you should be checking out the height of the P wave in all the ECGs that you encounter, and simultaneously you will also be having evidence of right axis deviation. Axis calculation is discussed in the ECG segment separately. I'll be doing a echocardiography of this patient, and one of the highlights that would be seen would be a thickened tricuspid valve. There is a possibility that the scan was done a couple of years earlier in this person also, but the mild tricuspid stenosis was initially missed. But now, because it has become progressively smaller, the size has become less than 1 square centimeter, so it's more liable to be picked up. The definition of the word severe tricuspid stenosis is the valve orifice less than 1 square centimeter. Remember, in mitral stenosis, severe is going to be answered as 1.5 and very severe is going to be answered as less than 1. So that difference has to be remembered. Another aspect which I can highlight in this movement is that, so imagine this is the narrowed tricuspid valve. This is the right atria, this is the right ventricle. So the time it will take for the blood to go across this narrowed valve will also be increased. So there's a possibility that he might incorporate one more echocardiographic criteria of transit time. Because of the narrowed orifice, I mean, just use simple physics here. If any opening is smaller, blood will take more time to go across that narrowed area. So the transit time in this patient will definitely be increased. So either he might put up a value or he might just say increased transit time, which is understandable primarily because in the patient there is a narrowed valve. Once I run a X-ray chest, mainly we will be having findings of right atrial enlargement. Even the superior vena cava of the patient will appear relatively more prominent. Even the azygos vein shadows will appear relatively more prominent. So there will be findings of right-sided enlargement of the heart and prominence of all the anatomical aspects that I have highlighted. You very well know that right ventricle does not form the right heart border. Right ventricle will be forming rather the base of the heart. Now, when it comes to the management of these patients, I will be using diuretics with a careful watch on the blood pressure, because these patients can be having ascites component present, hyperaldosteronism. So therefore, salt restriction will definitely be recommended for these patients, though it may not be, I would say, very practical because food tastes very bland with salt restriction. So lots of patients may not be able to ensure this. So you will be prescribing diuretics in these patients to ease off the pedal edema component. And the main treatment for these patients would be to initiate a valve repair. And if the valve cannot be repaired, then we will decide, like if it's a severe tricuspid stenosis, gross damage present, then we might even have to deploy a prosthetic valve in these patients. But anyway, we will first prefer a valve repair over a prosthetic valve deployment. So these are a couple of aspects which I want you to remember for the topic of tricuspid stenosis, and main highlight is this particular slide that's on the focus at the moment. I mean, if you get the features right, like pre-systolic pulsation, large airway with blunted Y, then you can be picking up not only presence of TS with MS, which is relatively easy, but isolated one as well. So thanks for your patience and hearing me out, and keep the focus on, and you guys are gonna do great. Keep hammering as I always say.